If you or maybe someone you know has ever tried to explain to a clinician exactly what's happening when your head feels, well, funny, you know how quickly things can just devolve into, like, frustrated hand gesture?
Oh, absolutely.
Are you dizzy? Are you woozy? Is the room spinning? It is, I think, one of the most common yet really confusing symptoms in medicine.
It truly is. And we're dealing with symptoms that, hide everything from simple dehydration all the way up to life-threatening emergencies.
Right?
So our mission in this deep dive is really to give you the essential tools to cut through that confusion. We're going to establish the critical distinction between dizziness and vertigo, and then sort of systematically sort the causes based on, well, when they happen.
Okay, let's establish that foundational difference right away then. I like to think of it this way. Dizziness is maybe like a loose wire, and vertigo is more like a broken gyroscope. How's that?
That's actually an excellent way to frame it for the learner.
Yeah.
When we talk about dizziness, we're describing that feeling of lightheadedness, maybe a loss of general balance or feeling faint, just a general sense of altered spatial orientation.
Kind of big.
Exactly. These symptoms are pretty nonspecific, and the causes often live more in the metabolic, cardiac, or general neurologic systems.
But vertigo, that's different. That is the abnormal sensation of motion. That is probably the single most important differentiating word here.
Absolutely. Motion.
It's the feeling that you are spinning or tilting or sinking, or maybe that the world is moving around you. When we hear that, our diagnostic pathway immediately shifts.
It does. It shifts right over to the vestibular system, so the inner ear and its nerve connections or maybe focal conditions in the brain itself.
Okay.
And our analysis today, it follows the necessary clinical approach. First, is it true motion? Is it vertigo? Or is it just generalized lightheadedness, the dizziness? And second, we sort it by timing. Is this a quick episodic thing, or is it persistent and acute?
Got it. So let's start with the dizziness pathway. This means the patient describes lightheadedness or feeling faint, but crucially, there is no abnormal sensation of spinning or tilting.
Right. And on physical exam, we expect that key finding of vertigo, which is involuntary eye movement, or in nystagmus, we expect that to be absent.
Okay, no spinning, no nystagmus.
So if this dizziness is episodic, it comes and goes, the very first thing we tend to investigate is orthostatic hypotension, or OH.
This is the classic, almost textbook definition of a trigger diagnosis, isn't it?
It really is. The trigger is purely mechanical,
Yeah.
moving from, say, a seated or lying position to an upright one, standing up, sitting up.
Right.
And the symptoms are almost cinematic, like you said.
Yeah.
Feeling your heart racing, maybe a sudden darkening of vision, or feeling immediately like you're about to pass out.
And what's fascinating here, and this is maybe the first really high-stakes clinical pearl, is that while OH is often linked to recent volume depletion, like you mentioned,
Vomiting, diarrhea.
yeah, or certain neurological conditions like Parkinson's causing autonomic dysfunction, that feeling of transient hypoperfusion, that sudden drop in blood reaching the brain, it can actually mimic far more serious cardiac problems.
That's the real trap, isn't it? You might be focused on, oh, they're just dehydrated. But that same feeling of seeing stars when you stand up could be caused by arrhythmias or severe aortic stenosis or even heart failure.
Wow.
So a simple postural change diagnosis really requires us to first make sure we are not missing a major cardiovascular issue. It's crucial.
And for OH itself, the diagnosis is confirmed pretty objectively, right? By a drop in systolic blood pressure of 20 millimeters of mercury or more.
Or diastolic of 10 or more.
Or diastolic of 10 or more. Yeah, within minutes of standing, those numbers are the key there.
They are. Now, moving along that same episodic dizziness track, we also have panic disorder. This is a purely psychological cause that can manifest as really powerful physiological dizziness.
Right. The presentation there is often these intense episodes of fear or discomfort, typically peaking within maybe 10 minutes, sometimes accompanied by hyperventilation, shortness of breath, or even chest pain.
Yeah, and we often see classic signs on examination like tachycardia, maybe some tremulousness, sometimes diaphoresis, sweating. But the real key is the history of intense anxiety or fear that's driving the physical symptoms, which then trigger that feeling of being lightheaded.
Okay, so that's episodic. Now let's talk about dizziness that is persistent or chronic. The most common cause here, especially in, say, older populations, is surprisingly manageable.
Medication side effects. It's so common. Often symptoms start soon after a new drug is introduced or maybe a dose is increased.
Which ones are typical culprits?
Well, antihypertensive medications and antihistamines are really common ones that can cause generalized sedation or maybe mild hypotension, leading to that chronic lightheadedness.
And the beauty of this diagnosis, I suppose, is in the simplicity of the test. The exam might be normal, but if you discontinue or adjust the medication and the symptoms resolve.
You've got your answer. Yeah.
Simple as that.
And finally, for persistent dizziness, we do have to consider post-concussion syndrome. This really demands a clear history of symptoms starting after some kind of head trauma.
Right. And the dizziness there is persistent and often associated with a whole package of other complaints, isn't it? Like chronic headaches, poor sleep, maybe emotional shifts, trouble focusing or remembering things.
Exactly. It's a constellation of symptoms linked to that prior injury.
Okay. So if you're charting this pathway in your head, no motion, no nystagmus, first, check the blood pressure changes with posture, check the meds list, and definitely check the history for recent trauma or signs of panic attacks. That kind of wraps up the generalized dizziness pathway.
It does. But here's where we really enter the high drama zone, if you will. If the patient reports the world is spinning, we are now squarely in the vertigo pathway. And honestly, the stakes automatically feel higher.
Right, because now we know we're likely looking at vestibular structures, the inner ear stuff, or potentially focal brain lesions. Gait impairment becomes common, and we are actively looking for that nystagmus, that involuntary eye movement on examination.
Exactly. So if this vertigo is episodic and recurrent, meaning it comes and goes but keeps coming back, we immediately focus on two main inner ear players that we absolutely must distinguish between. First, the most common one, benign paroxysmal positional vertigo, or BPPV.
Ah, the famous crystal problem. We're talking about those little dislodged calcium carbonate crystals, the otoconia, moving from where they belong into the semicircular canals, usually the posterior canal, right?
Precisely. And the clinical presentation is incredibly specific, which actually makes it fairly easy to spot if you ask the right questions. The episodes last only seconds, just brief, intense bursts of spinning.
Seconds, okay.
And they're triggered only by changes in head position, like rolling over in bed or tilting the head back to look up at something. Very specific triggers.
And crucially, because this is just a mechanical problem in those canals, there should be no associated hearing loss or ringing in the ears, no tinnitus.
That's a critical negative finding. No hearing issues. To confirm BPPV, we use the diagnostic maneuver that can be quite dramatic for the patient. Dix-Hallpike test.
Describe that for us because, yeah, it sounds like it's not for the faint of heart.
Well, it requires rapidly moving the patient. The neck is extended, the head is turned sharply to one side, and then the patient is quickly laid supine so the head hangs just off the edge of the examining table or bed.
Okay.
If it's positive, the patient experiences intense vertigo, and we, the clinicians, see that unmistakable upbeating and torsional nystagmus, that characteristic eye wiggle beating towards the affected ear. That confirms the crystal movement.
Wow. And the treatment is just as elegant in a way as the diagnosis, the Epley maneuver, which is literally just a series of specific head movements designed to roll those crystals back into the correct safe spot in the inner ear.
It often provides immediate relief. It's quite satisfying when it works. Now compare that brief position-triggered BPPV to our second major episodic vertigo cause, Ménière disease.
Right. Ménière is kind of the whole package of inner ear misery, isn't it? The episodes are much longer, lasting minutes to hours.
Hours, yeah.
And unlike BPPV, they typically have no apparent trigger. They just sort of happen.
That's a key distinction. No specific trigger. And we also see a classic symptom triad. True hearing loss, which often fluctuates, tinnitus or ringing in the ears, and a persistent sensation of ear pressure or fullness.
Okay.
This condition is thought to be caused by an increase in the endolymphatic fluid pressure within the inner ear. Too much fluid.
So if someone has spinning that lasts for hours, maybe their hearing feels off and their ear feels kind of stuffed or full, you're thinking Ménière.
That's the picture, yeah.
But if the spinning lasts maybe 10 seconds and only happens when they roll over in bed, you're thinking BPPV, and the Dix-Hallpike test would be negative if it were Ménière.
Absolutely. The timing seconds versus hours and those associated hearing symptoms are really the reliable separators here.
Okay, great distinction. Now we move, I think, to the most critical area, persistent vertigo. This is acute, new onset vertigo that just doesn't resolve quickly.
Right.
We are now dealing with what's called an acute vestibular syndrome, and the immediate crucial task is to rapidly determine if the problem is peripheral, meaning the inner ear nerve or labyrinth, or central, meaning the brainstem or cerebellum, which implies a potential stroke.
This is precisely where the HINTS exam enters the conversation. It's an acronym, HINTS, and it's a crucial diagnostic tool focusing on the head impulse test, nystagmus assessment, and the test of skew.
Okay.
This exam is specifically designed to be performed rapidly right at the bedside to differentiate a relatively benign inner ear issue from a potentially very serious brain event like a stroke.
So it's a high-stakes exam. Let's start with the peripheral acute vestibular syndrome, something like vestibular neuritis or labyrinthitis. What does the HINTS exam tell us is going on in the inner ear?
Okay, so for a peripheral cause, the HAT, the head impulse test, will be positive. This test checks the vestibulo-ocular reflex.
How does that work?
Well, the clinician rapidly rotates the patient's head toward the affected side, while the patient tries to keep their eyes fixed on, say, the clinician's nose. If it's positive, their eyes will momentarily break fixation and then quickly snap back to the target with a little corrective movement.
Ah, like a little patch-up.
Exactly, a catch-up saccade. That confirms a peripheral weakness on that side. The reflex isn't working properly.
So a peripheral problem makes the reflex weak, causing the eyes to need that little catch-up movement. Makes sense.
Correct. Then the nystagmus will be direction fixed, horizontal, meaning it always beats horizontally in one direction, usually away from the affected ear. And the test of skew, which checks for vertical eye misalignment, will be normal, no vertical shift.
Okay, so positive HITs, direction fixed nystagmus, normal skew, that points to peripheral. If we've established it's an acute peripheral syndrome, what's the final detail we need to split vestibular neuritis from labyrinthitis?
We just check their hearing. A simple way is the finger rub test right next to their ear. If the patient has normal hearing, we diagnose vestibular neuritis. That's inflammation of just the vestibular nerve portion, often following a recent viral illness.
Okay.
If the finger rub test is abnormal, meaning there is hearing loss, then the diagnosis is labyrinthitis because the inflammation involves both the vestibular and the cochlear, the hearing organs in the inner ear.
Got it. Simple hearing check makes the split. Now, contrast all of that with the really dangerous scenario. Central acute vestibular syndrome, signaling a problem in the brainstem or cerebellum, very often a stroke. What flips in the HINTS exam?
Pretty much everything, and crucially the head impulse test. The HEs, which is the most sensitive part for detecting stroke in this context, is negative.
Negative HITs means central. That seems counterintuitive.
It does, but it's the critical finding. Despite the rapid head rotation, the patient's gaze remains fixed on the target without that catch-up saccade. This is because the central brainstem connection for that reflex is actually intact, even though something else is wrong centrally.
Wow, okay. Negative 8s is the big red flag for central. What about the other parts?
The nystagmus will be much more concerning. It might be direction-changing horizontal nystagmus,
Right.
or it could be purely vertical or torsional nystagmus.
Yeah.
Any vertical nystagmus is very worrying.
And the test of skew.
It will be abnormal. We see a vertical movement of one eye when the other is covered during the alternate cover test. The presence of that vertical skew deviation is almost a guaranteed flag for a central lesion.
And I imagine, beyond just the HINTS exam, patients with central causes often have other, more classic neurological signs too, right?
Absolutely. Things like motor or sensory impairment somewhere else in the body, slurred speech, dysarthria, double vision, diplopia, or poor coordination, dysmetria.
Yeah.
These findings really mandate immediate imaging, usually an MRI of the brain.
Okay.
And yes, if that MRI confirms an infarction or a hemorrhage in the brainstem or cerebellum, then we have a stroke diagnosis. A really classic and unforgettable example is the lateral medullary syndrome, often called Wallenberg syndrome.
Right. Wallenberg syndrome results from an infarction of the posterior inferior cerebellar artery, the PICA, or maybe a vertebral artery issue. And its presentation is truly bizarre, isn't it?
It really is. You see this strange crossover loss of sensation, loss of pain and temperature sensation over the ipsilateral face, the same side as the stroke and the contralateral body, the opposite side.
Weird.
Plus, you often get this unique, almost random-seeming collection of symptoms. Intractable hiccups, severe hoarseness, and difficulty swallowing, dysphagia, maybe Horner syndrome on the same side, and ataxia, the coordination problems. It's the sheer complexity, the distinct localization that makes it pretty unmistakable once you know it.
Fascinating pattern. Less commonly, but still important, central vertigo can be caused by demyelination, right? Like in multiple sclerosis.
Correct, where we'd see multiple enhancing white matter lesions on the MRI. And just to round it out, chronic persistent vertigo can sometimes signal tumors, either growing in the cerebellum itself or tumors of the cerebellopontine angle, which often present with accompanying ipsilateral facial weakness, both upper and lower face.
Okay, so that's quite the landscape. We have moved from potentially just a simple feeling of lightheadedness, which might just need better hydration,
Right.
all the way through inner ear crystals and fluid imbalances to a full-blown stroke requiring immediate intervention.
It's a huge range.
So what does this all mean for you, the listener? We've covered a tremendous amount of ground, really differentiating conditions that rely on sometimes subtle distinctions in timing and triggers.
Yeah. And the real power here, I think, is the systematic approach. The diagnosis really hinges on just two simple initial questions. Is there motion? Is it episodic or persistent? Followed by a few absolutely crucial physical maneuvers.
Yep.
That dramatic Dix-Hallpike test for those brief crystal-induced episodes.
Right.
And the really essential hints exam for any persistent acute syndrome where you suspect something more serious.
And knowing this framework allows you to move past that frustrating ambiguity of just saying, I feel dizzy. You stop describing a vague feeling and you start, or help your clinician start, identifying a precise mechanism, whether it's mechanical otoconia, maybe an inner ear fluid imbalance, or hypoperfusion due to a specific drop in blood pressure, or something central. That systematic knowledge really transforms confusion into clarity.
It really does. And, if we just look back for a second at the hints exam, our sources highlight, and clinical experience bears out, that it's often more accurate than even an MRI scan in the initial hours of a stroke causing vertigo.
More accurate than an MRI initially. That's incredible.
It is. And it raises, I think, a really profound thought about the nature of our balance system. How has the evolutionary pressure on our vestibular system made it such an incredibly precise and efficient early warning mechanism? One that's capable of spotting a life-threatening brain injury, sometimes even before our most advanced imaging can confidently declare it. That deep connection between the inner ear and survival, that's a fascinating path maybe to explore on your own.